friends, thank you very much for invitation, and especially it's a great honor for me. It's a great pleasure, and especially thank you very much for my friend Lev Lapidus, who more than 35 years ago was the chief of my group during the education time, study time in St. Petersburg. As a concern to our clinic, I am the chief of the pediatric clinic, which one of the department of institute, and our clinic at our institute historically focused on the chronic pathology, chronic destructive pathology of the bone and joint. And in our clinic, we operate different patients from less than 1 year old till 18 years old, with different pathology, and this pathology included its focus on the destructive bone lesions, especially in primary chronic osteomyelitis. But during the last dozen years, we spread the focus of our interest and operated the patient with congenital pathology, with bone tumors, and other non-infective diseases. All data which I will show you, this is our personal data, and all patient was treated in our clinic. As to concern the spinal pediatric tumors, it's some stereotypes which could be discussed. It's counted the number of pediatric tumors, of spinal tumors is rare. It's counted that benign tumors significantly more than malignant tumors. And the third stereotypes is that the indication for surgery in malignant tumors is very rare, and the majority of these tumors have to be treated only by chemotherapy or radiation therapy. I understand that it's impossible to discuss about all problem of pediatric spinal tumors. That's why I just tried to show how many publications focus on this problem. It's a lot of publications focused on the spinal tumors in pediatric patients. But really, when we try to check this publication, for example, only 1 year, 2017, from 61 articles, only 4 articles was really focused on spinal tumors, because the majority of publication focused on spinal cord tumors, and 4 other articles was focused on the spinal effect in leukemia and spinal involvement in other, for example, paravertebral spinal tumors. Sorry? Okay. I will focus only some aspect of this topic: morphological structure, treatment strategy in uncommon situation, aggressive hypervascular spinal tumors, malignant spinal tumor complicated by neurological symptoms, and survival rate in operated and non-operated patients. The data which included into our report, this is the data of 3 clinics. 2 clinics was oncology clinic in St. Petersburg. This is a federal institute which located in St. Petersburg, and our clinic which only focused on the surgery of this pathology. The morphological structure of benign tumors is very different. Here is 14 type of tumor which could be established by morphology, and majority of them, this is osteoid osteomas, hemangiomas, and ABC, aneurysmal bone cyst. From the other side, for me, it's most interesting group of patients, which was separated from benign tumors during the last classification of international classification of diseases focused on oncology. This is the tumors which indicated as tumors of unknown malignancy or intermediate malignancy. This is Langerhans cell histiocytosis and GN cell tumors. You can see that in the last classification, it's indicated as a tumor which one or two type of malignancy, not 3, not 0. As to concern the malignant spinal tumors of spine, the most type of tumor is Ewing sarcoma. Other type of sarcomas is rarer, and in our series they presented as only one or few cases. Treatment strategy in aggressive hypervascular spinal tumors. It's an interesting question because when we try to see the publication, during the long period of time, they focused on chemotherapy, especially for giant cell tumor. But all publications dedicated the using of denosumab of this group, they focused on chemotherapy. But despite the effect of chemotherapy, they recommended the operation after chemotherapy because the long-term effect of denosumab is unknown. As to concern the ABC and hemangioma, there are different recommendations. Maybe it could be use only selective embolization, only surgery, and not too much article dedicated on combination of this method. That is why it was for us interested to compare the patient who was treated only by selective embolization and combination of selective endovascular embolization and surgery. We include into our study 11 patients with this type of tumors. The indication for surgery was deformity, paraplegia, and instability, which now counted by SINS, spinal instability neoplastic score. But this type of classification, this type of score is not applied and not frequently used in pediatric patients. All surgeries was done during the 3 days after selective endovascular embolization. The factor of analysis was absolute and relative blood loss in these two groups. In this group was included, as I saw previously, 11 patients with a different location of the tumor, and the result was unexpected for us. We didn't reveal any significant differences between the group with selective embolization and without selective embolization. But from other side, we have absolutely another sensitive during the surgery, because when we operated the patient with preoperative selective embolization, the feeling of surgeon is absolutely another. We operate without any nervous, any anxious, without blood loss during the surgery, and the time of surgery sometimes more longer than in patient without embolization. That's why today our impression that we prefer to operate this patient with selective embolization. The results I can show you. This is a patient with ABC tumor, which was operated with preoperative embolization with total reconstruction of spinal column. The another patient, it's a very interesting patient because he was 14 years old, and surgery was done due to mistake of morphologic diagnosis. The preoperative transcutal biopsy was counted by morphologists as a GN-bone tumors. At that time, we didn't use denosumab, and we operate with patient, but post-operative morphology was angiosarcoma. This patient is absolutely healthy 4 years after surgery without any recurrent of tumor. And this is the result of multi-level spinal reconstruction. And this is another pathology which could be maybe more known for orthopedists, but very rare examined by spinal surgeon. This is Gorham-Stout diseases, or maybe you know the syndrome of the bone of disappear bone. We have two patients with spinal involvement, one patient with hemangio type, and the second patient with lymphohemangiogenic type. I will show you it in another lecture. In this patient with hemangiogenic type, and this is interesting because after selective embolization, the patient, it was a girl, 15 years old, all her symptoms was completely disappear. This that was the reason because we cancelled from the surgery, and during the 3 years after this procedure, this patient is completely free of any pathological symptoms. We tried to form the algorithm for the treatment of this group of patients. And now we think that benign tumors, if it could be possible, symptomatic benign tumors, the best option for this is surgery. But for patients with hypervascular tumors, this is stage by stage selective embolization, and after that the surgery or chemotherapy if it's indicated, because sometimes we have, especially in patients with Langerhans cell histiocytosis, we have a patient with multi-level spinal involvement. Our conclusion concerning this part of pathology, selective embolization and endovascular embolization improve visualization of surgical field and support more anatomical research. Resection, and it can release clinical symptoms without surgery, but from the other side, without this procedure, we have more difficult surgery. We have to operate it more fast, and we have a problem which could be realized on ischemic myelopathy. Unfortunately, we didn't have any evidence of our decision because it's statistically not confirmed. The next question concerning the dynamics of neurological sign after operation in patient with malignant spinal tumors. This is a traditional algorithm for the treatment of the protocol of the treatment of malignant spinal tumor, but in cases of spinal cord compression, it have to be changed because the neurological symptoms is the prevalent symptoms in this situation. The other indication for surgery, instability and deformity, is on the second plan. From 32 patients with malignant spinal tumors, which we operated, 21 has different neurological complications. And as you can see, here the age of patients was different from 1 year old till 17 years old, and duration of neurological disorders always was more than 1 week. This is a problem because unfortunately the patient with acute neurological complication didn't come to the hospital during the early period. This is maybe because the problem of the big country. As to concern the results of the surgery, because this surgery included, as a rule, decompression and stabilization, we didn't know any deterioration after surgery in all cases. The neurological improvement was found in 62% of patients, but in all cases, during the 30 days after surgery, the improvement never was above 1 level of Frankel scale. This is, we established, it was for us very strange, and we didn't find any correlation between the initial degree of neurological symptoms and the degree of improvement of neurological signs. As to concern the survival rate of the patient with spinal tumors, it was established that despite the type of surgery, despite the time of surgery, because the period when we tried to connect the patient was very long. This is the data more than 70 years. This patient was connected to this group during the more than 70 years. The survival rate in operated patient was higher than in non-operated patient. That patient who only received chemotherapy or chemotherapy. That's why in the conclusion of my lecture, we didn't confirm correlation between duration of motor disorders and prognosis in this field. High level of neurological complication, and sometimes in patient with malignant spinal tumor, the neurological complication is the first symptom which patient complain. High level of compressive myelopathy and only one level of Frankel scale improvement after the compressive surgery in this patient. This is a few cases. This is a patient with complicated germ cell tumor of the spine. This is one of the patients which have the majority of complications after first surgery. We have liquorea, we have retroperitoneal phlegmona, and but despite this patient today is healthy. Another patient, this is a patient with Ewing sarcoma, and this is a patient with extrarenal rhabdoid tumor, which affected two vertebral body, vertebral rib, and after thoracic surgery and spinal surgery, he is alive during 4 years after surgery. And the last patient is a very interesting patient because this is a patient with chondrosarcoma of the base of the skull of the first and second cervical spine. After reconstruction, this patient was alive during 2 years, but she died at the age of 10 years old. Thank you very much.